Welcome, welcome, everyone. We're going to be getting started in just 2 minutes. It's great to see everyone. Good morning, everybody. It's so wonderful to see everyone today. We're really excited for today's program. I'm Fran Ayala Somiajla. I am the founder, co-founder of the Match Coalition. My co-chair, David Gray, is also with us. David, if you want to come on to the camera, that would be awesome for us. And I'm going to, so hopefully there's not too much of a feedback coming through from my computer, as we are also going to be recording today's program. David, if you'll go ahead with some opening remarks.
Great, thanks. And yeah, I see people starting to put their names and organizations in the chat so we know everyone is. I think that's a great idea. Strongly encourage everyone to continue doing that. So good morning. On behalf of the Match Coalition, I want to thank you all for joining us today for our spring, although technically it's summer, virtual Hill briefing. Each briefing that we put on, we like to choose a key theme in the maternal health space to highlight. Our theme for today is data and technology in action for maternal, mental, and behavioral health and well-being. I'm David, the Director of Government Relations and Connected Health Policy at HIMSS. We are a global advisor, thought leader, and member-based society committed to reforming the global health ecosystem through the power of information and technology. I also have the honor, more importantly for today, to serve as one of the co-chairs of the Match Coalition. The host of today's briefing. My other co-chairs are Fran, who you've met, and Elizabeth Frazee, who I believe she might be joining us later, but she is with Twin Logic Strategies. I think you're all familiar with the Match Coalition, but if you're not, the primary goal of our coalition is to promote better policies and guidelines that support the adoption and application of clinically appropriate technology for the betterment of maternal health outcomes by fostering activities and initiatives in the areas of research, education, and innovation. If you'd like to learn more or find ways to get involved, I strongly encourage you to reach out to myself or Fran or visit our website, matchcoalition.us. So during today's briefing, we will have a welcome message from Congresswoman Bonnie Watson Coleman, and we have a fantastic featured speaker, Dr. Dorothy Fink, very excited about. We were also hoping to have remarks from Congresswoman Nikema Williams, who is the House sponsor of the Tech Savings Act, but we had some tech difficulties and we're unable to make that happen today, but we will absolutely have her on a future meeting. Jumping right into the program, we are very excited again to have remarks from Congresswoman Bonnie Watson Coleman. She represents New Jersey's 12th Congressional District and serves on the Distinguished Appropriations Committee, specifically the Labor HHS Subcommittee. And critically for today's conversation, she is the co-founder and co-chair of the Congressional Caucus on Black Women and Girls and a longtime supporter and advocate and champion of addressing the maternal health crisis in this country. Let's try to get that video teed up for you. 1 second. Fran, do you have that video?
I think we're ready. Yeah, I think it's ready to go. It's just a little slow.
No problem. I don't think we can hear the audio.
Oh dear. Okay. Let's
There it
pause.
is. I think it was working. Might have just been a delay.
That's okay. Thank you, David.
Good morning. I'm Congresswoman Bonnie Watson Coleman.
This doesn't normally happen. So many technical
Good morning.
difficulties.
I'm Congresswoman Bonnie Watson Coleman, and I represent New Jersey's 12th Congressional District. And I'm honored to join you all today during your virtual Hill briefing. I'd like to thank the Match Coalition and Fran Ayala Soma Yajula for inviting me and for continuing to put a spotlight on the maternal health crisis. There is no surprise that America has a maternal health problem, but instead of making progress on this problem, it's getting worse. So few in this country fully comprehend the magnitude of the maternal health crisis in the United States. Currently, the United States has the highest maternal mortality rate among any developed nation, nearly 3 times the maternal mortality rate of France or Canada, and over 7 times the rate in Germany. Additionally, due to disparities in healthcare in the United States, Black women are also 3 times as likely to die in childbirth than white mothers. Their children are twice as likely to die in infancy as well. This is just unacceptable. As a nation, it is our responsibility to do more to not only address the country's maternal health crisis, but to repair the racial disparities within our healthcare system among Black mothers and their children. As we learned this week, Olympic medalist Tori Bowie and her child recently died during childbirth. A woman who was otherwise in peak physical condition did not receive the care that she needed, an all too common occurrence in the United States, especially among Black mothers. Our country failed Tori, and this has been the same morbid story for Black mothers time and time again. Can't keep allowing Black women, Black mothers, and their families to deal with this pain and suffering. We need to do better so mothers can access the care they need. To do that and to guarantee the right to health care for all, we must prioritize equity and repair the healthcare system, starting at its core. As a legislator, I am tasked with the responsibility of fixing this. In 2015, I first introduced the Healthy Mom Act to expand healthcare options for expectant mothers, and establish a special healthcare enrollment period to close the maternal mortality gap and to extend Medicaid coverage for 12 months following birth. In 2018, Congresswoman Robin Kelly introduced the Mamas Act, which comprehensively addresses the maternal mortality and morbidity issues. This bill would require CDC to work with states to improve their maternal data collection and surveillance, support grants for hospitals to develop emergency protocols and best practices, extend Medicaid coverage for postpartum women to 1 year, and require that HHS establish regional centers of excellence to address implicit bias among providers. The bottom line is, we have the technology, the education, and the training required to provide the care new mothers need. What we need is equitable distribution of these resources so no mother needs to suffer. Our present-day health disparities are not reflective of the quote-unquote shared goals of improving the outcomes of pregnant women. We can do better. We must do better. I'm proud to be in this fight, and I feel blessed that so many others are taking this to ensure that the United States is the best place on earth to have a child. God bless your work. God bless you, and thank you for what you do.
Excellent. What a wonderful presentation that delivered there by the Congressperson. Very inspirational. And we're very honored now to have David Gray to come back and join us and talk to us about some of the other legislation that is going on a federal level and the bipartisan activity that is coming along with that. David?
Yeah, absolutely. Yep. And again, a special thanks to the Congresswoman and her staff for facilitating this video and for all of her work and leadership, being a champion on Capitol Hill to end the crisis, focus on equity, eliminating disparities, and working for positive change. As Fran mentioned before we jump into our featured speaker, I just wanted to spend a few minutes highlighting some of the other key legislation in Congress. Fran, can I share screens, or do you have my slides up? Just want to. All right, there we go. All right, hopefully everyone can see this. So, again, I just quickly highlight some of the current legislation that we are seeing in the 118th Congress. We are already 6 months in. The first bill I really want to focus on, which I'm sure you're all familiar with since you're here and you care about this issue, is the Black Maternal Health Momnibus Act, or Momnibus. For those that don't know, again, I'm sure not many of you on this call, but the Momnibus Act is a comprehensive package of 13 bills, up from 12 last Congress, that really seek to address the maternal mortality crisis through historic investments and policy and regulatory changes that address every driver of maternal mortality, maternal morbidity, and maternal health disparities in the United States. This Congress, the Momnibus Act was introduced on May 15th, one day after Mother's Day, and each of these bills that I've called out that comprise the full Momnibus package have been or will be introduced in the House and Senate as standalone bills. Some of them bipartisan, which is incredibly exciting to see. That gives them sort of a better chance of passing. The Match Coalition is a huge advocate and supporter of the Momnibus package as well. But given our focus on information and technology, we are incredibly enthusiastic and supportive of the Data to Save Moms Act, HR 3320 and S 1599, the Tech to Save Moms Act, which is S 1699. It has not yet been introduced in the House, though we hope for it to be introduced as a bipartisan bill in the coming days. And the Social Determinants for Moms Act, HR 3322 and S 1594. All these bills are fantastic bills, but those three specific bills really leverage digital health tools to address different drivers of maternal mortality. Next slide. The But the Omnibus Act is not the only primary focus maternal health bill in Congress. Last year, we were incredibly fortunate through the hard work of congressional champions and stakeholders off Capitol Hill to see a number of maternal health bills signed into law. The Rural Moms Act, the Maternal Health Quality Improvement Act were both signed into law, as well as the Protecting Moms Who Served Act, which is the first standalone omnibus bill that's signed into law. We're going to continue pushing Congress and pushing the administration as well as states to enact regulatory changes and legislative changes that leverage information technology. Some of the comprehensive and bipartisan bills that we will be focusing on this year that have already been introduced, and we expect a number of other bills to be introduced, are the Healthy Moms and Babies Act, S948, that's led by Senator Grassley. This is a bipartisan bill that focuses on a comprehensive solution that includes telehealth and the use of remote patient monitoring. The Connected Mom Act, or the Connected Maternal Online Monitoring Act. This is a bill that would leverage remote patient monitoring for state Medicaid programs to treat pregnant and postpartum mothers. The Mothers and Newborn Success Act, S964. This is another bipartisan bill that would include the use of telehealth to improve maternal health outcomes. And the last bill to note, although there are many others, is the Preventing Maternal Deaths Reauthorization Act of 2023. This is a bill led by Congressman Michael Burgess in the House, and it reauthorizes a bill, the Preventing Maternal Deaths, that was signed into law in 2018. All of these bills are bipartisan. They all make great strides to address the horrible and worsening crisis that mothers face every day in this country. And if you'd like to learn any more about the Omnibus or any of these other bills on this slide, or if there are other bills that I have not mentioned that you all are tracking and following, please do not hesitate to reach out. The primary goal of Match as an advocacy organization is to advance sound evidence-based policies around information technology. So we strongly welcome your input and support. And with that, I will stop sharing, and I'm going to turn it back over to Fran.
Wow, thank you so much, David. We appreciate that overview. What progress. That's amazing progress that we've been making. And I know that, it often doesn't feel that way, right? We are just working really hard day in, day out, and there's still so much work to be done. But I think, and yes, Megan, I think we should all celebrate and give a round of applause to ourselves and for all of those who aren't here today, but who are out there busy every day, making a difference in the lives of mothers and families everywhere. It's a lot of hard work. And if you're in healthcare, you know that this is you're playing the long game. These things don't happen overnight, and it's equally so, unfortunately, within the political arena as well, as legislation ebbs and flows and things come and go. But it's very, I think it's very heartwarming and makes for inspiration to know that these are topics that we can all come together on and work together to make a difference. So congratulations.
Fran, and sorry, one thing I forgot to mention.
Yes.
We will be, as we've done in the past, HIMSS and the Match Coalition will be launching a grassroots advocacy campaign tool through Quorum that allows the general public to reach out directly to their elected federal officials to urge them to co-sponsor and apply pressure on congressional leaders to take up and pass these bills. We will be launching that in the next couple of weeks, hopefully next couple of days. We're waiting for the Tech to Save Moms Act to be reintroduced in the House. And as soon as that is up, we're going to launch that campaign, and we would really welcome everyone's participation and sharing that through their networks. Because that's really what it's going to take to get these bills over the finish line, is enough pressure from their members' constituents. So just wanted to put in a plug for that.
We're so glad that you did, David. Thank you for taking a moment to do that for us. And now we're really excited to get ready for our today's guest speaker. So honored to be able to have the opportunity for myself to actually introduce one of our very active members of the Match Coalition, who I'm trying to get here onto the spotlight. We'll go ahead and ask for Megan, if you don't mind putting on your camera for us. Thank you. Megan Simmons is with us. She is from the National Birth Equity Collaborative. She'll introduce herself and today's guest speaker. So to you, Megan.
Thanks so much. Good to see everybody today. My name is Megan Simmons, and I'm Director of State Policy Programs at RH Impact, formerly National Birth Equity Collaborative, or NBEC. We're a proud member of Match Coalition. It's my honor to introduce our speaker today, Dr. Dorothy Fink. Dr. Fink is Deputy Assistant Secretary for Women's Health and Director of the Office on Women's Health in the Office of the Assistant Secretary for Health at the U.S. Department of Health and Human Services. Dr. Fink brings an extensive experience treating women's health issues. She is board certified in endocrinology, internal medicine, and pediatrics, and is recognized as a physician leader on topics such as diabetes, nutrition, and bone health. Previously, her clinical practice focused on women from adolescence through menopause and beyond. Thanks so much and welcome, Dr. Fink.
Thank you so much for having me today, and we're excited to talk with you all and really focus on the data and technology aspects of maternal health. So I will go ahead and get started. Okay, so in the Office on Women's Health, we really do focus on women and girls across the lifespan. And so I'll do a few introductory slides, and then we will get into some more of the programming. At the OASH Office on Women's Health, we really look to ensure that all women and girls achieve the best possible health. And so we look to provide national leadership and coordination to improve the health of women and girls through policy, education, and innovative programs. Here you can see as we think about women and girls' health really across the lifespan. And the beauty of maternal health is that it really does have us impact health across the lifespan as we think about the different points where we can work to truly make a difference in health outcomes. In terms of areas that we focus on and our unifying goal is to really be always thinking about, what is the evidence that is out there? And today we're going to be talking some more about maternal mental health and how can we really ensure that all of these things that we are aware of from the evidence-based practice standpoint are really implemented through both policy and practice. Here you can see the Coordinating Committee on Women's Health that we lead, which is truly a way that we bring people together across HHS and beyond through the federal space to impact women and girls' health outcomes. And this map here you can see is how we implement a lot of our maternal health work as well. I'm going to share with you a little bit of an overview of some of the projects that we have across the office, many of which have to do with maternal health. And so here you can see some of our FY23 grants. And as you can see below, there are on a number of topic areas really looking at a lot of upstream factors from a public health standpoint that impact maternal health. And then also on areas that we're focusing on in particular from the perspective of reducing postpartum deaths due to drug overdose, as well as looking at violence and substance use prevention. I'll also share with you today some of our challenge competitions, and please feel free to reach out regarding any of these if you're interested in learning more. A number of these challenge competitions specifically focus on aspects of data and technology to address disparities. And so you can see our breastfeeding challenge, our hypertension challenge, our HHS racial equity and postpartum care challenge, which also specifically focuses, has one of its focus areas on maternal mental health, and our endocrine disrupting chemicals innovator award competition. And so we don't have a lot of time to go into all the details of these today, but always happy to share more with you all. The focus of today is really going to be on our project looking at maternal morbidity and mortality through data and analysis. And so one of our goals at HHS and through the maternal health blueprint with the White House is really a strong commitment to thinking about how we can garner data to really have the most up-to-date information to inform our policies and programs. And so through the White House leadership and working closely with them, we're excited to share some of the work we're doing, focusing specifically around maternal mental health. And so the data that I'm going to share with you here are descriptive results. And so we'll look forward to sharing more with you all in upcoming months as we have this information statistically analyzed and then eventually published as well. But as we're thinking about the maternal health outcomes, we really want to make sure that we're addressing maternal mental health. That is a cornerstone of the White House Maternal Health Blueprint, and we really are committed to ensuring that we have the resources to address mental health as it relates to all aspects of maternal health. And so in this first graph, you can see mental health conditions among deliveries and the trends from 2008 to 2021. And you can see how maternal mental health conditions have increased on an average of 1.5% per year since 2014, and then really have doubled since 2016. And so we see this increase. Additionally, we look at this National Maternal Mental Health Analysis from 2008 to 2021, and can see here that American Indian women have the highest documented mental health conditions rate. Then you can also see that Black or African American women and white women also have very high rates of mental health conditions. But really appreciating that mental health conditions can impact anyone, and so much of our work is really looking to make sure that we can find the people who are at the highest risk and ensure that we have appropriate interventions to ensure that they can have the best outcomes possible. Now, how does mental health relate to maternal morbidity and mortality? That's something that we want to make sure we're addressing, because we know the impact of mental health and how we want to make sure that we're not having maternal morbidity and mortality as a result of that. But here, these slides show not great news when it comes to severe maternal morbidity. And so in this descriptive results, so again, we'll be getting further analysis of this, but here you can see that patients with mental health conditions are 1.5 more times likely to have one or more severe maternal morbidity diagnoses. Furthermore, and again, descriptive results, but we're going to be diving more into this, but looking at in-hospital delivery-related maternal mortality rate is over 3 times higher for patients with documented maternal mental health conditions. And so these slides show trends that really underscore the importance of addressing maternal mental health. When we think about maternal mental health, the data that we're looking at was specifically focused on severe maternal morbidity and mortality, but we also know that many of these complications can occur in the postpartum time period as well, which we'll get to in just a little bit when we look at some of the readmission data for maternal mental health conditions. And so this, in the prior slides, we were looking at inpatient data. Here, we're looking at inpatient readmission for psychiatric treatment within 1 year of delivery. And so here you can see within the 1 year of delivery, mental health conditions were documented during the delivery visit in 51% of cases, but in 49%, mental health conditions were not documented during the delivery visit. And so we know that while we want to address the maternal mental health conditions that can occur during pregnancy, that it can directly impact the delivery itself, we know that in the time period afterwards, that mental health conditions are a really important factor to consider, and they're not necessarily something that we're thinking about if it hasn't been documented during that delivery. And so how do we also impact this 49% of women who weren't necessarily flagged as a risk factor for maternal mental health conditions, but then end up being readmitted for a condition. And so there is a lot of work to do in this area. Also important to note, and this has been documented in other studies as well, that women delivering during the time period of 23 to 33 weeks experience nearly twice the rate of readmission for psychiatric treatment compared to women delivering after 33 weeks. And so also something to think about in terms of risk factors for maternal mental health complications is, what happened during the pregnancy, during the delivery, and how can we ensure that we note these risk factors and address them before complications ensue. This is also another slide looking at the race ethnicity for readmission for mental health conditions per 10,000 deliveries. And so similar to when we were looking at the prevalence, American Indians have the highest rate of mental health readmissions per 10,000 deliveries. But then we also can see here that both Black or African American women, white women also have readmission rates in the double digits, as well as Hispanic women at 9 readmissions per 10,000 deliveries. And so these are all disparities that we want to make sure we're addressing and that people are aware of so that we have the proper support in place and that we are addressing the health equity aspect of maternal mental health. Now, a lot of our work too is thinking about the maternal and infant health dyad. And so here you can see neonatal abstinence syndrome per 10,000 neonates, and the rates of unadjusted NAS have increased by 33% in our data from 2016 to 2021. And so when we think about that dyad, we think about the postpartum readmission rates and, how can we really be addressing this both during pregnancy and postpartum is something that the department is very much so committed to. And within OASH and across the department, there's been a lot of incredible leadership around neonatal abstinence syndrome. So that was some of the data part of discussing maternal mental health today. And we're now going to transition into the task force on maternal mental health, which was part of the omnibus language this year. And so we're working very closely with SAMHSA to collaborate using the Coordinating Committee on Women's Health to implement this task force. This task force is co-chaired by Admiral Levine, who is the Assistant Secretary for Health, as well as the Assistant Secretary from SAMHSA, who will be co-leading this group and ensuring that we are able to coordinate the federal response to maternal mental health, closely working with all of you as we're taking next steps on this task force. And so there will be a number of different announcements coming from the department shortly about this task force. And we look forward to engaging with many of you who are on this call and listening as well as we address maternal mental health in the US. And then finally today, I'd like to share a little bit more about ways that we are addressing both the technology and data aspects of maternal mental health. And this is going to be through a campaign that we'll be launching later this year, talking postpartum depression. And so this campaign has been in the works for a number of years. It is specifically focused on postpartum depression, although we appreciate that, there are a number of different mental health conditions that can occur across the life spectrum for maternal mental health. This specifically focused in on doing a lot of audience segmentation work around specifically postpartum depression. And the goals of this work are really to destigmatize PPD through increased awareness of symptoms, visibility of reliable resources, and understanding ways to access care. And we'll really have an emphasis on reaching populations most at risk for developing PPD and utilize the lived experience of diverse women across the country. And so stay tuned for this. It will be launched later this year in coordination with the larger efforts. This is part of the White House blueprint to address maternal health. And we look forward to this announcement as we make the final preparations for it. Some of the campaign assets include, all sorts of media work, partnership engagement. And so please be on the lookout for that. If you are an organization focused on maternal mental health and would like to learn more, please reach out to our office and we're happy to share. And so the planned launch will be in the fall of this year, and we'll be having all sorts of announcements around this, and we're really excited to build on a lot of the work that HRSA has done over the last year with the HRSA Maternal Mental Health Hotline, and look forward to being able to continue the work across the department and in support of the White House Maternal Health Blueprint in terms of addressing mental health. And so this last slide just shows some resources to connect with us. And as I said, if you are an organization focused on maternal mental health, please feel free to reach out to us. We'd love to learn more about your work as well. And that concludes the presentation today. Happy to take any questions.
Thank you so much, Dr. Fink. That was amazing. Really a phenomenal overview of some of the terrific work that you're doing. To get us started and sort of warm us up in terms of questions, would love for you to kind of explain and share with us a little bit about the differences between organizations, right? There's the CDC, they put on their campaigns and they're obviously conducting research. There's the work of HRSA and the grants that they're busy funding and some of the initiatives that they run. But those are all very specific and separate, right, from the work of the Office on Women's Health. Can you kind of describe for us a little bit of your organization, how you differ and how you perhaps complement the work of these other institutions?
Of course. And so on that slide that I showed for the Coordinating Committee on Women's Health, it really is a visual that looks at, our office, the Office on Women's Health, and how we coordinate with offices and agencies across HHS. And so all of our work really aligns and complements all of their work. As you all know, HRSA has led incredible work with the AIM program, and then in collaboration with the CDC, with the PQCs and the MMRCs. And so all of this is part of a coordinated response to address maternal morbidity and mortality and maternal health at all levels from the federal government. So we do work very closely with them. And we're all committed to ensuring that we really think together and have a way to get to updated information that can really inform our policies and practices.
Absolutely love it. Well, if you don't mind stopping the share of your screen there, then we will transition over and we'll invite others to come on to put their cameras on, and we'll make it more of a town hall feel, if you will, in a virtual setting. So folks are welcome to join. Megan, if you want to go ahead and also put your camera on, and others as well. David, see, there's lots of folks out there. Jonathan and Miriam, there are many others. If you'd like to join us, that would be wonderful.
Fran, you also have their videos spotlighted.
Oh, is that what's happening? I feel like it's the amateur hour today. I'm normally a little bit more polished than this. What is going on?
Okay.
You send me to DC and now I can't help myself. I'm actually in DC today. I think I'm a little bit still getting through the jet lag of waking at what was starting my day at 5 a.m., which when I started it, I guess, quite earlier than I normally do. So thank you guys for your patience today as we go ahead and take the first question. David, if you'd like to kick us off, that would be awesome.
Yeah, sure. So, looking at some of the data that you had, all of the trends are really going in the wrong direction. Were there any sort of factors that you see playing into that? Was it that, our ability to record the data and understand the data is getting better, or the data collection processes are better? Has the problem always been as bad as it is now, or have things gotten worse? Is that something you were able to parse out in your analysis?
Sure. So as we're looking at this, a lot of times we have the lists that the CDC has worked so hard to develop on, for example, severe maternal morbidity. And so we have that list. There aren't specific, maternal mental health conditions on the severe maternal morbidity list, right? And so something that we're trying to do through this work is figure out how can we make some of those connections to better understand those severe maternal morbidity factors and what is kind of feeding into them. And so at this point, we don't necessarily have data to better understand, what factors are specifically impacting this severe maternal morbidity factor or that one. And so at this point, we're really just trying to use the data, the technology to make as many connections as we can, and then work together across HHS to really think about how we can best coordinate our responses. And I welcome, I have, I think on the call here, where we're working very closely with Premier on this project. And so if anyone else would like to add in anything on the line, you're more than welcome to share. But with much of this data, we're making connections that have not yet been studied. And as I mentioned, a lot of this is hot off the press, looking at trends, and we'll have the 2022 data very shortly. And of course, are very much so happy to continue to share with you all once we have it statistically analyzed and have more information about this. But it is, really hot off the press and really trying to take us to the next level. Because, when you look at that severe maternal morbidity list and you say, pulmonary edema and aortic aneurysm, or whatever diagnoses you may see there, say how does this connect to things that people understand? Like how does mental health impact those? And so I think that as we really take the next steps to make some of those connections, we'll be able to better understand some of the risk factors that play into those and how we can best address them.
So you have a couple of hands up. I believe Asha, your hand was up first.
David, my question is more of a follow-up, and thank you for bringing this data to a group of really engaged stakeholders who can take it and run with it. But my question was, on the first slide, you showed that, and I appreciate the fact that this is still descriptive and there has to be analysis and all of that, but something that really stood out to me was that the maternal mental health conditions increased 1.5% per year. But then in 2016, they have since doubled, right? So that's a huge increase. And so I'm just curious, from your perspective, what do you think happened in 2016? This, I know David followed up, asked a question somewhat about this, but what happened in 2016 that maternal mental health conditions then doubled? Do you have any ideas on what the cause of that was?
It's a great question, and I hope we can come back to you with more answers. Right now, we're pulling that and looking at the different codes that come under maternal mental health. And when we think of maternal mental health, we're also looking at behavioral health too. And so how can we think about substance use trends as well during that time and better understand what are the drivers? And so, like I said, hot off the press information, and would love to be in touch with you as we have more information to share on that.
And then I believe Susan, your hand was next, and then Miriam.
Yeah, hi everyone. Sorry my video didn't go on. It seems to not want to, but in any case, good morning everyone. I'm from Premier, and thanks Dr. Fink for that great presentation. And as you said, we have a lot of analysis to do to find out to statistically look at what has made that change. In 2016, I think of important note is the fact that that SMM does not have currently maternal mental health measures in it. So as we look to bringing that in as part of the definition, we're going to be able to learn more and more about different conditions and how they relate. And it's extremely important that we begin to do these deep dives. As we know, I live in Massachusetts, and we've had a couple of events in the last several months that are extremely awful, I'll say, and catastrophic. And so we all know we have a lot of work to do, and we are looking forward to diving into this deeper this data in a deeper way to find this out.
Great comment. And Miriam, you have a question for us? Welcome.
Hi, Fran, and thank you for inviting me. And this is such an important conversation, and I am so upset that I missed most of it because I'm with patients and I'm actually in between patients. One question that I have, for the first time, I think mental health complications have become the leading cause of maternal mortality. But when I look at various conditions, strokes, thromboembolism, cardiomyopathy, those conditions are often analyzed separately when they really should be looked at under one umbrella of cardiovascular complications. So the question that I had is, why are those conditions looked at separately? Or I don't know, I believe there is someone from the CDC there. If they could help me understand why they are looked at separately, because then I wonder if that could lead to an unintended distraction in looking at the root causes of cardiovascular complications.
So you're saying independent of maternal mental health conditions, just all of the different cardiovascular conditions that fall under that umbrella?
Yep. We look at them separately, right?
Yes. Mm-hmm.
But cardiovascular diseases are diseases of the heart and blood vessels. So when we piecemeal one blood vessel complication from another blood vessel complication from one heart disease to another heart disease, then we end up diluting those etiologies from looking at them all under the umbrella of cardiovascular complications.
Right, that is a great point. And I'm not sure if anyone from the CDC is on the call today, but there's a lot of thought that goes into some of these processes, and we're happy to get back to you on that. But thank you for sharing.
But thank you.
Maybe we can piggyback off of that a little bit. In so much as we know that the data does already show us that individuals with chronic diseases or comorbidities have a propensity to have higher rates of depression and other forms of mental health challenges. And we also know that many comorbidities are becoming increasingly more prevalent among pregnant individuals. We've just heard from Dr. Dustin, who referred to cardiovascular disease. We're seeing more women with type 1, type 2 diabetes, individuals who have congestive heart failure, all kinds of conditions, comorbidities. And then, of course, you take conditions like even gestational diabetes, where we tell women not to worry, but who would not worry when we know that there are other challenges that can arise post-pregnancy associated with having been diagnosed with gestational diabetes. So how might we begin then, Dr. Fink, to look at these conditions and how they may impact the mental health and well-being of individuals, particularly when we start talking about creating preventative measures? How might we take those into consideration? Preeclampsia, someone's commenting from the Preeclampsia Foundation, of course, preeclampsia being another one, and there's so much in the news about that. How do we manage that? How do we communicate as community community organizations and providers of care and makers of policy around supporting women with comorbidities?
That's a great question. And when we look at the trends, we know that all those comorbidities have really skyrocketed since like the 1980s. It's horrifying, right? And so how can we, and then we think about what has happened to maternal mental health too. And so, there are many ways to think about it. Of course, we want to go as upstream as possible from the public health perspective to try to say, how can we prevent some of these comorbidities from occurring in the first place? But then saying, okay, well, we know that so many of these comorbidities are a reality that are not going away anytime soon, despite our best public health efforts in terms of addressing a lot of chronic conditions. And what our work through this project is looking at too is to say, how can we better understand? And so, the earlier question about why the rise in maternal mental health conditions and better understanding, I shared that slide looking at prematurity and its impact on maternal mental health, and just think about some of the factors of chronic conditions that can have an impact on prematurity. And so many things are interrelated, and our work is, and our goal is to really better understand some of these drivers so that we fully appreciate the relationship between both physical and mental health, and how can we work from both perspectives, because we know that just saying, okay, you're at risk for postpartum depression. Well, what does that mean? How can we really say and better understand those risk factors and address them as far upstream as possible? So those are great points. Thank you.
Thank you for that very thoughtful response. And it looks like we have a question that may have been posed in the chat as well, coming from Valerie, who says, in what ways can we refocus the maternal health, maternal mortality discussion towards whole person integrative care for better maternal outcomes? What is the role of data and innovation in regards to this opportunity?
Sure. Well, I can start off by saying, how do we make maternal morbidity and mortality become something that there are horrible complications that occur, and for many people, you don't think that it could happen to you. You think you've gone through the steps, and then you have this terrible complication that happens that is so drastic and awful for families. And so how do we take what's are really hard conversations, right? I mean, what are having those conversations and really think about how we can take these complications that can occur and make some of those risk factors come alive for people in a way that can enable us to do more prevention efforts. So I think that better understanding some of those risk factors will help us make what can be a complicated discussion of, well, what is severe maternal morbidity, make it become more realistic, and help people to better understand what those risk factors are. But then, I think something that I also want to say, though, is there has been such incredible work that has been done across HHS in the past years, whether it's the incredible work through the quality improvement work of AIM, through the PQCs across so many states. I mean, there's been so much focus on quality improvement in these areas, and we're now beginning to see the impact of those. When you first start doing quality improvement, it's not always something you can say, oh, well, in our hospital, we saw this change, but what does that mean for a national level? And so really thinking about, the incredible impact that these programs have had on a national level from a quality improvement standpoint, and knowing that we're not always going to be able to perfectly address everything in an upstream approach. And, you all know preeclampsia, it can happen out of the blue no matter what you do, right? But we have, really incredible work that has been shared through the both organizations like yourselves, as well as a lot of the work that has been led by both HRSA and the CDC in these areas over the past years, and really focusing in on how we can address both quality improvement at, during the delivery time period, but then also thinking, more of both upstream and downstream, as HRSA is doing through their work with AIM and expanding that beyond the delivery period. And then I don't know if there were some other hands up. If anyone would like to add anything, please feel free.
I think you're right on the money with that, and certainly sprinkling in there the technology and what the technology can bring to it and the visibility that it offers, right? That we're only scratching the surface when we think that the collection of data that comes about from individuals presenting themselves in a clinical setting is the beginning and the end of a story to be told. There's so much more, and we've even seen that from having anthropologists, social anthropologists right here sharing with us some of her findings from the stories of women across the country, and from many of the technology providers who are right here today on this call, who are gathering biopsychosocial data, which certainly has an opportunity. Believe that we're so close to time. I'm going to pass it back over to Megan with any with the final thank yous and any closing remarks before we end up closing off today's call. Megan?
Hi, folks. Thanks so much for joining us today. I hope it was informative for you. I hope you have had the opportunity to connect with folks to further the work. And we really appreciate your time and attention today. Thanks so much to our guest speaker. Learned a lot, and thank you for being so thorough with the information that you presented.
Sure, and we're happy to share, more as we have the statistical analysis and more information for the mental health, but then also the physical health standpoint as well. And for anyone on the call or listening, please feel free to reach out to us. As we had mentioned, we're launching that PPD campaign, and so anyone with any thoughts on that, would love to hear from you, and look forward to being in touch.
Wonderful. Dr. Fink, thank you so much. Megan, David, so greatly appreciate it. We're so honored to have had everyone with us today as part of our spring virtual Hill briefing. Of course, we do this twice a year, so the next one will be in the fall. And we, again, thank everyone for being with us. If you have any questions, looks like there's a lot going on in the chat window as well. And the Preeclampsia Foundation does encourage everyone to also equally reach out to them. So we do ask you to do that. And we'll just keep our eye on that data coming. It'll be here any day now, right? Maybe, possibly, Dr. Fink?
Yeah, so we'll definitely keep you posted.
All right, we'll be watching. Yes, that's right, Charisse. Our fingers are crossed. Thank you, everybody. Have a wonderful rest of the day.
Okay.
Thank you, everyone. Thank you, Dr. Fink. Can't wait to have you back.
Yes.
Thank you so much. Bye-bye.
Thank
Bye,
you.
everybody. Thank you.
Bye.